Very good evening to one and all. At the outset, I thank the organizers of AMSI Masterclass for having me here on this wonderful platform. It's always a pleasure to interact with enthusiastic students. Learning is a continuous process, and we still continue to learn and evolve every day to provide better care for the patients. When Dr. Sruthi told me about this topic and shared me the recordings of this earlier cleft theory sessions, as well as the wonderful panel discussion on this platform, which has comprehensively covered the theoretical aspects, I'll try to confine my today's talk to how to go about with the clinical examination and few areas which I felt wasn't covered in earlier sessions, and also possible theory and viva topics which the postgraduate students may focus on. So these are the two primary areas that we will be focusing our attention on. There is no clear demarcations. Some areas I will try to highlight the important aspects during the clinical examinations as well. There will be some students who will be blessed to work in colleges associated with cleft units or might be having peripheral posting in amazing cleft centers. And of course, there will be few who may not have seen or seen a very few clefts and might have difficulty in understanding the wonderful world of clefts. I thank my faculties and amazing mentors for guiding me through my journey in clefts. I hope to pass on what limited understanding I have on this topic to my colleagues and also learn from them. One day you will tell your story of how you have overcome what you are going through now, and it will become part of someone else's survival guide. So, few essential books that are going to help you on this journey or is going to make this topic a lot more easier to understand are the following. And the very recent addition in the textbook from AOMFSI, which is in my times was in there. I'm recently going through this wonderful book. A few important questions which has been repeatedly asked in previous years in various universities are the following. Postgraduates may take screenshot of it if needed. I have put in relevant articles for additional reading in coming slides. You may note down the same. Before we get to the topic, those who haven't watched the earlier Cleft sessions on AMSI Masterclass may go through the same, as in our limited time, it won't be able to go in details of all the theoretical aspects. So you can see how anxious the parents of cleft children are, and especially on what future they may hold for their child. The way the news is delivered will influence how the family understands, responds, and ultimately copes with the challenges of parenting an infant with cleft lip and palate. So, as clinicians, we must have solid foundational knowledge about a cleft lip or cleft palate or combined disorder to provide a better care for the infant and to educate the family as a whole. The case history part is similar in most ways, like any spectrum in OMFS, but some focused history taking is essential in clefts, especially antenatal exposure to potential teratogens, specifically explore the use of prescribed medications, recreational substances, tobacco and alcohol consumption history, noting the timing, duration, dose of each exposure, review of use of protective agents such as prenatal vitamins, especially ask the mothers when they started on folic acid prior to conception and thorough throughout whether they had taken it throughout during pregnancy. Review the antenatal care, including the timing of ultrasounds, whether it was performed and whether anomalies was visualized, and especially the growth status of the fetus. Also take a note of who the informant for all these informations are. So the chief complaint, as you know, can be documented as per the informant's own words. And coming to history of presenting illness, you can ask from where the delivery of the child was, whether there was any complication during birth, what child was preterm or term, if it is an operated child, whether the operation occurred, where the place where operation was done, at what age the operations were carried out. This will help to understand what was previously done, as many parents are not familiar with the repair techniques, but surgeons are often aware of the types of repair performed in different areas of the world. The physical examination can provide further clues as to what was previously performed, especially the scar around the nose and lip can alert the examiner to understand the primary or the secondary technique that was gone in this child. Animations can help to examine and understand the status of underlying orbicularis or its muscle. Intraoral examination may reveal which operations were done on the palate and also identify the presence of whether any oronasal fistulas and the status of levator muscle, the length of soft palate, as well as presence of alveolar clefts. And an intranasal examination will help you determine whether primary rhinoplasty was performed, the status of nasal septum, the patency of nasal cavity. A proper speech assessment will determine the functionality of the palate and whether more tests are needed in this child. And the past history, like we already discussed, what all are the prenatal, the postnatal issues the child had, what surgeries have been already undergone. And in birth history, we can classify it as antenatal history, natal and postnatal, and age of mother during pregnancy, and as discussed whether the mother had taken any medication during the time of pregnancy, whether child mother had undergone any abortions before, and in postnatal history, whether child had any childhood diseases, history of accident or trauma, any difficulties at the time of birth, any respiratory issues or breathing difficulties, was the child in incubator or on ventilator supports, and the habits which the child had, especially the tongue sucking, lip biting, nail biting, mouth breathing, tongue thrusting habits, etc. It is very important to take a note on the immunization history as well as the developmental milestones. Sometimes parents may not be aware of the immunization importance, or they may not be aware of uh, the developmental milestones, especially when it comes to operation point of view in these children. And in family history, you need to understand whether the parents had undergone in consanguineous marriage, the sequencing of the child, whether the siblings had any clefts, the status of sibling, the general and the overall health condition of these children, any known person in the family had any clefts, details of his or her locations and where the surgeries were carried out. And extraoral examination, general extraoral examination include the shape of the head, the facial form, the facial profile, eyes in particular, the any intercanthal distance discrepancy, which indicating hypertelorism, interpupillary distances, nose appearance, any deformities on the nose, ears, upper lip, lower lip, retrognathia or the position of the chin, presence of any facial clefts and associated classification also you have to take into consideration. Any other systemic issues also you have to take a note. So in coming to physical assessment, like we discussed, infant's head size, the shape, symmetry, the overall general appearance, infant face, note for any atypical features, evaluate for the asymmetry and the movement of the in the facial uh, muscle. Look for asymmetry of the eyes, nose, mouth, the spacing of the eyes, width of the nasal bridge. And while evaluating the mouth, you need to evaluate the length of the philtrum, the size of the mouth, tongue, whether there is any macroglossia, microglossia, macrostomia, microstomia, macrognathia or micrognathia, retrognathia, width and thickness of the lips, and in lips, especially the lower lips, you can look for any shallow lip pits, which are characteristically seen in syndromes like Vanderwood, artificial digital syndromes. So, few syndromes which you can keep in mind were the children associated with cleft having lower lip pits. And this is how you can examine a patient with cleft palate. You can ask your assistant or the nursing staff to stabilize the and the mother to hold on to the limbs, and you need a well lit illumination and a tongue depressor. This is also helpful even in post-operative evaluation of cleft palate. So coming to infant's cleft palate, you need to understand the shape of the arches, the vertical palatal shelf, how wide the cleft is, position of the vomer, whether the uvula is bifid or uvula is deviated to the side, whether there is an asymmetry or the length of the soft palate, and a complete systemic head-to-toe physical examination in these children is essential. And anthropometric measurements also will be helpful in assessing the growth aspect in relation to the growth chart. Systemic examination and other congenital anomalies should also be taken into consideration because various congenital anomalies reported in literature include the skeletal system disorders, the nervous system disorders, heart, cardiac diseases, respiratory system abnormalities, polydactyly, deformities to eyes, ear, limb anomalies, chromosomal disorders. Then there is anencephaly, spina bifida, etc. We shall see a few important clinical features in the coming slide. But this book will give you a good overall description of how to go forward with assessment in a pediatric patient. So, like we said, it is not just the extraoral examination of the face. The overall examination is important. Characteristic clinical features like the polydactyly, extra fingers on toes are some of the characteristic features. Syndactyly can be also seen. Preauricular ear tags, sometimes unilateral or bilateral, is seen. Uh, Another characteristic features seen in this are the coloboma, or it may be associated with syndromes. And examiner might ask you microtia grading as well, because these are also ear deformities are also characteristics of cleft deformities, like ear deformities like microtia, anotia, ear deformation, middle diseases. So take a note of the microtia grading and the associated classification and possible treatment options in these children. So common syndromes that are associated with EL malformations are the following. So you also keep in mind a few of these names just in case the examiner asks you. This is Talipus equinovirus, what is called as clubfoot. This is how the normal looking limb will be. This is how it is in congenital clubfoot. And cardiac anomalies are quite common. You need to look for cardiac murmurs, uh, rule out any cyanotic or acyanotic cardiac diseases. Paratractology, transposition of greater vessels, pulmonary atresia are very common in children. And this is one good article, a systemic review and meta-analysis, which is going to help you in answering few of the Viva questions. And common neurological anomalies are midline hypoplasias, associated midline clefts, spina bifida. Spina bifida is generalized term for neurological condition resulting from the failure of neural tube closure of varying degrees during fetal development. There is a common folic acid deficiency that is associated with spina bifida as well as cleft disease. So maybe folic acid has a role in preventing spina bifida as well as clefts, though we can't say for sure. And usual dental anomalies seen in cleft children are the missing teeth, extra teeth, delayed tooth development, abnormal tooth number, malocclusion, collapse of constricted arches, microdontia, developing crossbite, locked up premaxilla, which is commonly seen in a bilateral cleft where the cleft segments have collapsed in and the premaxilla is locked out. Sometimes expansion of the arches might be needed when child comes for bone grafting. So all this need to be taken into consideration in your case history and clinical examination. So coming to the local examination, I'm sure in your theory aspect how you have understood the characteristic clinical features seen in cleft lip and nose and the alveolus presentation. In case you still have a doubt, you may go through these figures, how what is called as a columella, what is filtral column, the filtral dimple, what is white roll, what is nasal sill. All this you should understand. Knowing the normal help you in understanding the abnormalities. So coming to evaluation of patients in cleft lip, you need to know take a note of the side, the degree of cleft, width of the cleft, Simnard's band, alveolar cleft, whether it's a partial or complete, width of the alveolar cleft. That is this is what you called as a greater segment, that is the non-cleft side, and this is a lesser segment, that is a cleft segment, and the discrepancy on the anteroposterior discrepancy as well as transverse dimension, presence of cleft palate. If so, you need to give the details of the cleft palate, position of the major and minor maxillary segment, which I just described, dentitions, like we already described on the dental anomalies, position of the premaxilla, whether it is to collapse to one side, whether it's a midline, or whether it is locked out. All this you need to take into consideration. So, in coming to the nasal deformity, what all you need to look at: the width of the nostril, orientation of the nostril opening, position of the columella, the nasal tip, the nasal alar, soft triangle, whether there is any alar webbing, the present position of the nasal septum, the nasal dorsum, and degree of deformity varies with clefts. So in the technique also, you need to address each of these deformities in whatever way is possible. Okay. So this is Hoffman and Lair characteristic clinical features seen in cleft lip and nasal deformity. I'm not going to details. If you are interested, you may go through this article. And characteristic clinical features of cleft nose are the following. This is a beautiful diagrammatic representation where you can see the nose appears longer on the cleft side than the non-cleft side. The cleft nostril is wider and retroplaced, and there is a characteristic internal vestibular web with inward buckling on the cleft side alar base. So you can see the deformation on the cleft nostril, how wide the segments on the nostrils are, and you can see the inward buckling as I mentioned. You can see the characteristic internal buckling, and the cleft side alar base and the piriform is slightly displaced posteriorly and laterally. Posteriorly and laterally here you can see, and the maxilla is deficient on the cleft side. There is more flattening on the paranasal area. The columella and the caudal septum and the premaxilla is deviated to the non-cleft side. And you can see the anterior nasal spine is deviated to the non-cleft side. And the medial crest, you can see it is short and the lateral crest is long. So they form a obtuse angle. So all these are the characteristic clinical features which you can appreciate in a unilateral cleft. Then what all you can anticipate in a bilateral cleft? The nose is mostly symmetric. There you have a broad tip. The dome of lower lateral cartilage is separated. And here you can see the columella is short. And what you can appreciate, the alar base is laterally displaced. There is a wide nostril. Vestibular webbing is present on both sides. Medial crura is short and the lateral crura is long, and they form a characteristic acute angle. There is a protrusive premaxilla. So this is what you call as the premaxilla. And these are the various clinical presentations. So you can see in a bilateral cleft, here you can see a partial bilateral. You can see a partial bilateral. Here you can see the premaxillary segment is attached to the partial side, and there is a complete cleft on the uh, left side. Here you can see partial cleft on both sides. And here you can see the premaxillary segment is completely collapsed to the right, and there is a larger segment, I mean, larger defect on the left side, sorry, left side. And this is in the premaxilla is almost in the midline. So the various characteristic clinical presentation also you need to take, especially postgraduates who don't have much exposure to clefts. And this is one area I don't think was mentioned in the theory aspect. This is what we call as a Seminard's band, this band of tissue. Though it may be characteristically called as a complete cleft, if the width of the band is more, then sometimes there might be an ambiguity in classifying it as a partial or a complete. So here you can see the width of the cleft is, width of the band is somewhat more. Sometimes people may call it as a partial cleft, or sometimes people may call it as a complete cleft. So this is what you called as a Simonard's band. So there are some ambiguities which are still not resolved in a cleft world, especially with regard to classifications. So people call as per the convenience. So the thing that you need to keep in mind is the basics, classifications, clinical features, what all you need to look in a normal child, how you can differentiate the normal structures and abnormal structures. So know the normal and find its place and place it in normal position. This is as quoted by Ralph Millard. This will also be golden words that you need to keep in mind while operating clefts. Okay. So all these things, I am sure that has been dealt in the theory topics. What are the principles of cleft repair? As quoted by Stephenson in 1953. Interested postgraduate may go through this article. Then what are the goals of unilateral cleft lip surgery, bilateral cleft surgery? All these can be possible viva questions. And the main thing is repaired lip should pass off as normal one. Okay. Coming to palate child, you have already understood how to examine a cleft child, and you need to look in palate. whether the palate is operated or unoperated, the width of the cleft, wormer, whether in complete wormer, which side the wormer is attached, in bilateral wormer, whether wormer is collapsed to one side or other side, soft palate, the length of soft palate, whether there is an asymmetry, uvula is deviated to one side or not, mandible positioning, whether there is retrognathia, whether Pierre-Robin sequence, position of the tongue, whether there is macroglossia, or how much is the mouth opening, because if the mouth opening is less, and you will have difficulty in operating as well. Accessibility might be an issue. So you can see various clinical presentations in an cleft palate. You can have a asymmetric soft palate. And this is one thing you need to keep in mind. This is what you call as a submucous cleft palate. You can see a translucent line. The diagnostic triad are the bifid uvula, translucent zone in the soft palate, and bony notch in the posterior edge of the hard palate. These are the classic clinical triad as quoted by Kalnan, and postgraduates may go through this article. These are, you can see the bifid uvula, translucent line, and when you palpate, you will see a bony notch in the hard palate, so soft palate junction. Okay. And there are various other clinical presentations, and you can see the wormer is in the midline. It's a moderately wide cleft. You can see how the palatal shelves are. This is a partial cleft, that's a narrow cleft. And you can see how the palatal shelves are oriented. This is a slightly vertical palatal shelf. This is more or less an horizontal palatal shelf. This is what you called as a wormer. Sorry. This is what you call as a wormer, one you see in the midline. Here you can see the wormer is attached to one side. This is a unilateral cleft. This is here also wormer is attached to one side. This is a unilateral cleft. In bilateral, wormer is attached in midline. Here you can see wormer is collapsed to one side. So all these clinical features, especially for postgraduates who don't have much exposure in clefts, you need to understand the various clinical presentation that will be helpful in clinical examination as well as the theory part. Okay. Coming to investigations, X-ray will help you in understanding whether the child is having cardiomegaly. If the width of the heart is more than 50%, you need to suspect cardiomegaly. An echo may be essential to rule out any congenital heart disease. And then in the usual things, the final diagnosis, the treatment plan, treatment done, what surgery was done, performed, surgical notes, all these are important. So these are all the primary things that when a child is unoperated lip or palate, and sometimes secondary cases can be shown to you from the exam point of view. This is a case of fistula. Operated palate child, you need to evaluate for a cleft palate fistula and how the child is speaking as well. There are various presentations that can happen in fistula. You need to understand the classification, the famous Pittsburgh fistula classification, and common options that you can do to close the fistulas, and how you can assess or evaluate VPD. Most of the thing we have already discussed in the initial history taking, like what type of surgery was done, the pregnancy history, complications, how many surgeries has already been done, whether speech therapy sessions has been already done on a regular basis, developmental history, and dentition status, all these things you need, whether there is any presence of submucous cleft. I hope the postgraduates still remember the triad by put forward Kalnan. The soft palate length, symmetry, degree of elevation, symmetry of during phonation. All these are other aspects that you need to note in your case history taking or clinical evaluation in VPD. These are on the secondary aspects. Like I said, slightly older child is presented for a case. So you can summarize like any maxillofacial case history, you can summarize, and you should come up with a provisional diagnosis and treatment plan. So most of the questions we have already covered. Few pending questions are, so like it's like any theory question can also be asked as a viva question. Problems for a child in cleft palate, you have the feeding, nasal regurgitation, and speech. The postgraduates, even not from exam point of view, should know how to give counseling for a child with a cleft palate. You can see the various clinical presentations in cleft, unilateral, bilateral, and if it is a unilateral, child can be fed from the non-cleft side. If the feeding is not done properly, the milk will go into the lungs, and there is frequent respiratory issues, and there is a chance of aspiration as well. Okay, so feeding instruction should be given properly to the parent that in the initial visit itself. See how the mother is holding the child in 45-degree, in a head is slightly raised, especially the palate when it's opened, the child mother will have difficulty in feeding the child. The whole idea is the milk should go into the stomach and nowhere else. So you should give proper counseling on how to go about with the feeding, how to hold the baby, and how to feed the child, either by expressing milk from the breast directly or by giving any soft feeding bottles which is compressible. And you should allow the child to swallow, give him time, and burp periodically before feeding, in between feeding, and after feeding. By burping, I mean by, you can see how the mother is expressing milk directly. The bottle should be sterile. You can either give cow's milk or formula feeds when the mother is not having adequate breast milk. So that is a overview or initial counseling that you can give when the mother is coming for the first visit with a cleft lip or cleft palate child. So why speech is affected in cleft palate child? That is another question, because of it is because of the escape of air and how it is escaping. When we speak normally, what happens is velum should close with the posterior wall of the pharynx, and there is complete uh, movement of air through the oral cavity. This is how the normal airflow should be. But when in clefts, there is not complete closure, and the air escapes the nasal cavity. So that is how the speech is going to be affected in a post-operative cleft palate child. And why there is ear problems, and what are the ear problems? Because of the cleft palate, there is a communication between the uh, eustachian tube, and there is a middle ear infection. Usually serous otitis media is seen, and our ENT colleagues may need to insert grommets. And one palate is operated, obviously there is a growth issues seen in the maxilla, so growth problems can be seen. So these are the other set of viva questions. And other possible questions are, what are the other congenital anomalies seen in cleft children? Risk factors of orophacial clefts, which we have already seen few. And you need to understand what is Pierre-Robin sequence, the classic triad. And this article is very much helpful from exam point of view. There are various treatment modalities in Pierre-Robin sequence is described. And just brief overview on the risk factors. I'm sure most of these have already been covered. Etiology also need to be understood. Maternal smoking, heavy alcohol consumption, multivitamins, folic acid, drugs, pre-pregnancy, during pregnancy, diabetes mellitus, obesity, environmental contamination. All these you should understand or elicit during the case history presentation. The syndromic and non-syndromic clefts, you should name a few syndromes associated with orofacial cleft, at least the famous ones like oculofacial kabuki syndromes, which is not common, but it is seen. Opitz syndrome, orofacial digital syndrome, Vanderwood, Toucher-Collin, Stickler syndrome. All these things are very much important. And these are the characteristics syndromes seen associated with cleft palate. Spilocardiofacial syndrome is important. Vanderwood, golden heart, ectodermal dysplasia. So these are the few syndromes and characteristics, clinical features. If you can keep in mind, it will be helpful from viva as well as theory point of view. This wonderful article will give you a complete picture of the embryology and genetic aspect in cleft lip and palate. Embryology is another question, possible question area, and the different structures forming the lip and palate, the timelines, all these things you need to keep in mind. What are the palate and the different genes that is involved in the normal facial structure development as well as in cleft children. And you can see the various prominences that is forming the facial structures. Any defect in this fusion results in various types of cleft. You can see a microform cleft. This is a oblique cleft, partial oblique cleft, and you can see a lateral cleft, SCA number 7, nasal cleft. So there are various clinical presentation, bilateral cleft, midline cleft, mandibular cleft, auricular clefts. So postgraduates need to understand the Tessier cleft classification and the naming system in abnormal facial clefts. And this is one area I felt that it is not being taken in the theory aspect. Few theories that you need to understand is the embryological theories, fusion of a process by Darcy and his, and failure of fusion happens. And then there is Fleischmann, Wu, and Stark mesodermal migration uh, failure that put forth by Fleischmann, Wu, and Stark. So these are all given nicely in volume one of Cleft, and other small few theories which are staining in 1939, Tondre in 1955 or in 1966. Or if you can name a few, is also helpful from a Viva point of view. Sometimes even from the theory point of view. Palatogenesis, the vertical palatal cell forming in the midline by turning into horizontal plane and fusing in the midline. So all these structures, how they are forming, you should keep in mind the muscle, the normal and anatomy and the cleft anatomy, and the blood supply and vasculature is also important. So coming to another case scenario, say like imagine a 1 year or 1 year, 3 month old child comes to you. It's an unoperated lip and palate. What be your priority now? Any guesses? Obviously, it is a speech that is a concern. At the time of 1 year, it's time for palate repair. There is no particular timeline for lip repair because speech is important. Before child starts speaking, you need to operate the palate. So for operate palates first when the child is around 1 year, even if the lip is not operated, and whether you need to undergo any further in what all investigations and you need to be understood. You need to rule out any systemic issues. Then what is the aim of the cleft palate surgery? We have already seen the technique of cleft lip and palate repair. We will briefly go through now. And you need to understand the blood supply, nerve supply, muscles of all these things. And retractor, that is another area. This is a wonderful article, mouth gags, advantages and disadvantages. This is how a normal gag is, a cleft palate gag is. You need to understand how to put it. Sometimes your boss might ask you to put a in a cleft palate surgery. So you should understand it without keying in the tube. Classification is another possible question area. And there are various classifications. I'm sure which it's already described in the theory session. Davis and Ritchie classification, Brophy. Then there is O classification, 1931, embryological perspective classification by Fogg and Anderson, Lal-Slash system of classification, Fernand-Stark classification, and the refinements by ACPCA. International classification by Broadman, Spina classification, Karnan's classification, which was again modified by El-Sahi and Millard. All these are possible Viva questions as well as theory questions, which you should keep in mind. Then there is a classification even for microform clefts. Interested candidates may go through this article. You can see micro, mini form clefts, mini and microform clefts. With microform clefts in various dimensions are there, and this is another classification which is quite popular, Nagpur system of classification. And this is the Tessier classification for facial clefts starting from midline to extremities. This is two good articles. If you are interested, you may go through this. And another possible Viva area is timeline for surgical treatment with different cleft care providers that are involved at what stages where what different surgeries or interventions are done. This can come as a Viva theory, even as a major question for exam. This is a wonderful article. You may go through this from the clinics of. It's an excellent article. Will help you in theory. And rule of tens, which was put forward by Williamson and Musgrave. It was wonderfully discussed in the panel discussion. It was later modified by Millard in 1976. From for theory point of view, we can keep in mind, though we don't follow much today. And this is another important aspect from both from theory as well as Viva point of view, history of cleft lip repair, few names and the classical techniques that has been come in literature. You should keep in mind right from the very Rose Thompson straight and repair to Mirault, Limousin, triangular flap technique, which is also called the stencil method. The various other triangular flap techniques, the triple wedge technique by C. Balakrishnan, the molar modifications. What is a modification? What is Millard's technique? First, you have to understand, then you need to understand what are the modifications to Millard, node of Chen technique, the Pfeiffer and Afros incision. So various modifications, even for Millard technique has come. You should understand what is the principles of Millard. All these are Viva questions. The advancement flap, what is rotation, what is a back cut, and various modifications that have come forward. You can go through this article that even Millard Cleft has described beautifully. This is another interesting article, the various modifications given by various prominent authors. If you can diagrammatically draw in all this for theory exam, it is very much beneficial. So, what are the points that you need to do in a classic Millard? That is also a possible Viva question. How you come up to the marking of the lateral ambiguous point, various methods. That also you need to keep in mind. I'm not going to detail because I'm sure all these I've already covered from the theory point of view. What is Fisher anatomic subunit repair? It is basically a measure twice, cut once repair compared to a Millard's cut as you go approach technique. This is how my markings are. I'm not going to details. Then the modifications of C flap. What is C flap? That also you need to understand. What is advancement? What is rotation flap? What are the nasal interventions that you can do in a primary lip surgery, whether it's a closed dissection, semi-open, or a open dissection, septal repositioning. So many things that can asked from the theory that can be extrapolated to the Viva aspect. I'm not going to much details because I'm sure all these I've already covered. Just to give an overview on all these things, I just put it. And you can see the various clinical presentations of a lip partial, complete, various types of partial cleft. Sometimes Simnard's band, the complete cleft, another complete cleft. Another important topic is the nasoalveolar molding. I'm sure it has already been discussed in the theory session, and how various techniques you can modify mold the nasal and the alveolus. So you can see the wide cleft with a characteristic clinical presentation, which we've already discussed. Quickly go through. This is all for the benefit of the postgraduates who don't have much exposure to clefts. And another Viva question, different techniques of cleft palate repair. You have the Langenbach technique, Vovadil Kilner, Bardak two flap technique, Furlow's double opposing C plasty technique. Here you can see Vovadil Kilner VY palatoplasty. You can see the Furlow's double opposing C plasty. Just to break the monotonous, there is something beautiful about all the scars, whatever be the nature. A scar means hurt is over, wound is closed and healed, done with. So, and as postgraduates and upcoming cleft surgeons in making, be it wide or narrow clefts, there is no room for error in clefts because the future of these children is in your hands. This we have already seen how we can evaluate child with cleft VPD, but what are the treatment options or how we can, what are the parameters that options that is available to check VPD? You have nasometry, video fluoroscopy, nasoendoscopy. Now you have MRI as well. And what are the treatment options? We have various pharyngoplasties. You can use the pharyngeal flap and the buccal myomucosal flap. Just, I don't think it was dealt in theory aspect. Few names you should keep in mind. It was posterior pharyngeal flap was put forth by Pasavan in 1865. Schonborn in 1875 described the inferiorly based pharyngeal flap. Then later, after a decade, he described the superiorly based flap. And Paget in 1930 was first to popularize the superiorly based pharyngeal flap. And various techniques of pharyngoplasty are the sphinctopharyngoplasty, organs, Furlow's and superiorly based pharyngeal flap, Heinz pharyngoplasty. Just in case if pharyngoplasty comes as a short note or as a Viva question, you should name a few. This is a Mann's or Robert Mann's operation where you use buccal flap as a primary as well as secondary palatoplasty technique. You can see how buccal flap is used to close primary repair, and in secondary case, a transverse incision is made in the midline, and double opposing buccal flap is placed to lengthen the soft palate. And here you can see the various characteristic clinical presentations on the cleft palate. No two clefts are same, be it in width, muscle, clinical presentations. So that makes this specialty unique. You can see a short sword palate, uvula pulled up. You can see you should not be doing the same technique for all clefts because no two clefts are the same. And you can see buccal flap used. This is furloughs. This is the ACRP technique where the buccal flap is used for primary repair, primary palatoplasty. So that is the journey through the wonderful world of clefts. Here you can see the how the child was in the birth, how after nasomolding. This is after lip repair, and another beautiful looking child. This is immediately post-op. This you can see the collapse segment with the great. Hope you are remembering the greater segment and the lesser segment. Another wide cleft. So various clinical presentations, various characteristics presentation, just for the benefits of postgraduates who don't have much exposure into clefts. So I hope this talk was useful for you all. I think I've taken more than 20 minutes. But I hope it is beneficial for most of the postgraduate students, especially for the ones who don't have much exposure to clefts. Anyone who has any doubts may contact me in person. And all the best for all of you. I thank once again the organizers for MSI Masterclass for giving me this platform and to interact with the energetic group of postgraduate students. Thank you. Thank you once again.